Let me now invite the first speaker, Dr. Pranashis Saha from Bangladesh, to speak on salvage therapies in BCG failures for non-muscle invasive bladder cancer.
Good afternoon, everybody. First of all, I must thank the organizers and the Little Miracle for this nice opportunity. Let us go through our topic, salvage therapies in BCG failure for non-muscle invasive bladder cancer. This is a very short history. In 1921, Calmette and Guerin isolated the antigenic bacilli, and in 1970, BCG was approved for bladder cancer treatment. And in 1976, Morales, with his colleagues, first published the results of intravesical BCG 6 weeks installation. And intravesical BCG is the cornerstone treatment in intermediate and high-risk non-muscle invasive bladder cancer following surgical resection. However, approximately 30 to 40% of patients receiving BCG treatment may experience failure. And these are the guideline recommendations as a salvage therapy in BCG failure non-muscle invasive bladder cancer. Number one is radical cystectomy. Second option is non-extirpative intravesical agents. And third option is clinical trials. Come to the first option, radical cystectomy remains the standard of care in BCG failure patients. Early cystectomy with BCG failure non-muscle invasive bladder cancer is advantageous. And radical cystectomy raises disease-free survival up to 80 to 90%. This is a few data from our cystectomy series for non-muscle invasive bladder cancer, where 223 cystectomy were done for BCG failure, and in our series 5 years disease-free survival was 87%. But radical cystectomy has significant morbidities with quality adjusted life expectancy. And what to do if the patient is unfit or unwilling for the surgery or wants to be enrolled in the clinical trials. These are the salvage therapies for unwilling patient or unfit patient. This is non-extirpative, commercially available agents to be instilled in the bladder. These are chemotherapy and immunotherapy, which can be instilled single, combined, or in sequential form. Among the chemotherapy, valrubicin is the only FDA-approved intravesical agents, and immunotherapy, pembrolizumab, is the FDA-approved intravenous agents following the results of Keynote 057 results. And another option is trimodal therapy, where radiotherapy and chemotherapy is used following the surgical resection. But this trimodal therapy is not suitable for carcinoma in situ. These are the agents not commercially available, called the novel agents, to be used for the bladder conservation as drug delivery system, photodynamic therapy, vaccine therapy, and gene therapy. All these agents showed the promising results. And this is the recent review study published in this year, where 70 studies with 27 treatment options were analyzed. And in the commercially available agents group, 12-month complete response rate were more pronounced in single gentamicin and valrubicin study, and also in the combined study, which ranges from the 82 to 83%. And in the novel agents group, 12 months complete response rate were more pronounced in the drug delivery system and photodynamic therapy, ranging from 85 to 91%. And these are the ongoing clinical trials in BCG failure non-muscle invasive bladder cancer of different phases with chemotherapy, immunotherapy, gene therapy, vaccines, drug delivery system, and the chemoradiation. So our take-home message is that patients with BCG failure are heterogeneous group and outcomes may be different. Consensus guidelines are warranted for the unmet need for salvage therapies. Interim results of clinical trials with novel therapies are promising. Cystectomy is the standard of care till to date. Thank you for your patience hearing, and thanks to all.